You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. This is part 1 in a 3-part series on murmurs in children in the ED. Today on part 1, we'll apply what we know about normal physiology to the not-so-normal presentations we sometimes see in the ED. In part 2, we'll go over pathologic murmurs and how not to miss them. Part 3 will be a piggyback focus-on episode to drive home some of the maneuvers we can use to distinguish the scary from the expected. Now, I know we've all learned this over and over again through memorization and maybe mnemonics. They have their place, but without a core of understanding, without a physiologic template in our minds, these memory devices just get us to that next test, and they fail to become an essential part of our dynamic physical exam. I'd like to review briefly what we should know about murmurs before we see the patient, and then apply what we know to that patient right there in front of us. The physical exam is a test you do yourself. The turnaround time is immediate. The results are right there in front of you. But like any test, before you order it, before you do it, you have to ask yourself, what am I looking for? This is especially important in murmurs because heart sounds in a little chest beating fast can get very muddy very fast. We use our history to prime us for how to listen. Of course, depending on the chief complaint, there's going to be a big difference in how carefully or how long or how thoroughly you'll listen to someone's chest. If a parent tells you on review of systems that the child has a history of a murmur, but they're just watching it, or it's an otherwise healthy child without symptoms, it's probably going to be an innocent murmur. There is, of course, a differential for innocent murmurs, but if you hear something that doesn't match this, we need to do more. Similarly, if in, let's say, the infant who's not feeding well, or maybe has some sacral edema or hepatic congestion, you better believe that you'll be listening for that holosystolic, harsh murmur that radiates to the precordium. More on that very special disorder next one. On history, we'll gather information on the child's perinatal course, any concerns for genetic syndromes. In infants, you'll want to know if there's excessive fussiness or difficulty with feeding or concerns about breathing problems. In older children, you'll ask about dizziness, syncopal symptoms, family history of cardiac disease or sudden death. All of those things, of course, you do automatically already. After this good history, you may find yourself in a few scenarios. Maybe you're in reassurance mode, the incidental murmur that the parents already know about and it's not likely related to today's chief complaint. Or you may be in screening mode, a new murmur that you found today, and again, you're trying to decide, is this incidental or essential to today's visit? Or you may find yourself in diagnosis mode. This shortness of breath or syncope or failure to thrive is possibly linked to something you can hear with your stethoscope. And yes, the stethoscope has not been replaced by the echocardiogram. Each has its place. The point here is that you want to listen in context. Just to tune our ears, let's listen to a normal heart. In children, especially in the scary ED, you do the best you can with what you got, and you really want to go from the least invasive to the most invasive. So work your way up to them. Chatting in a friendly way with mom or dad, slowly, indirectly, making our way closer to the gurney, little distraction, talking about things on the wall. You're giving them a chance to size you up. Is this a dangerous stranger or a new friend? You can ask mom to bring the child's shirt up, looking for dysmorphic features, work of breathing, maybe a precordial heave. Then you can feel for a thrill, feel for pulses. Are the femoral pulses weak? Should this be a sign of coarctation of the aorta? Are the pulses bounding, meaning a large difference between the systolic and diastolic pressures? Could this mean aortic regurgitation? And then you can ease in your way to auscultation. After the ventricles are primed with blood, it's showtime. They contract, causing the atrioventricular valves to close, which causes that S1 sound. The aortic and pulmonary valves will open quietly. After the rush of systole, the ventricles relax and are ready to receive blood. On the right side of the heart, the superior and inferior vena cava return poorly oxygenated blood back into the right atrium, through the tricuspid valve, and into the right ventricle. On the left side, well-oxygenated blood from the 4 pulmonary veins drains into the left atrium, through the mitral valve, and into the left ventricle. During diastole, the tricuspid valve on the right and the mitral valve on the left open silently. At the same time, the aortic and pulmonary valves close, which makes that S2 sound. Now, that's all a perfect scenario, but valves can be tight, stenotic, or insufficient, regurgitant. These are the main pathologic murmurs, but there are plenty of extra sounds and clicks and growls and squeaks in that cardiac jungle that we should be accounting for. And luckily, many of these are going to end up being benign. Up to 50% of children will have some murmur, and up to 70% of newborns will have a murmur when they're born. The good news is that the vast majority of murmurs in children are benign or innocent. Only 1% will have some congenital heart disease, so our goal here is to either reassure or to refer if we can't reassure ourselves. In general, benign murmurs are soft, they're short, they're systolic, and they have a normal S1 and S2. They're also stronger when supine. Safe sounds are soft, short, systolic, with a sweet-sounding S1 and S2. Picture this. You're lying back, relaxed, and that murmur really loves it when you chill. It's soft, short, and systolic. Pathologic murmurs are the opposite. They're loud, they're long, they're harsh, they're diastolic, maybe even holosystolic. They're extra clicks and they're louder when standing. Pathologic murmurs are troublemakers. They stand up, shout for a long time, even when they're supposed to be resting. A quick review of the grading of murmurs, grade 1 through grade 6. Grade 1 is very, very faint and usually just made up. Grade 2 is a soft murmur. It's heard in all positions. There's no thrill. These are where most benign murmurs are. Grade 3 is moderately loud with no thrill. Grade 4 is loud and you have a palpable thrill. Grade 5 is very loud. There's a thrill and you can hear it with a stethoscope partially off the chest. Grade 6 is a crazy loud thrill, and you can hear it with the stethoscope just before you touch the skin. Maya is a 7-year-old girl who came to you for some mild dysuria. She's okay. You're getting a urine, and you do your doctorly duty and listen to her heart and lungs, and you hear this. That's not a murmur. It's an extra heart sound. It's an S3, heard just before S2. Recall that S2 happens during diastole. When the pulmonic and aortic valves close, blood pours into the ventricles from the atria, and the ventricles can become distended quickly. The reverberation of that robust blood flow is what causes that extra little gallop after S2. Instead of lub-dub, it's lub-drub, lub-drub. In adults, we immediately associate an S3 with volume overload for good reason. In children and young adults, however, S3 can represent a problem if there are other signs and symptoms of heart failure, but in the asymptomatic child, it can also be a normal finding. The S3 is a very low intensity sound, and in a noisy environment, it's hard to hear. The S3 is dull and it does not radiate. Children, adolescents, young adults, especially pregnant women, may have a normal third heart sound, in which case we'll call it a physiologic S3. Maya is fine and no one needs to worry about this normal finding in this healthy child. Marcus is a 14-year-old boy who is here for toe pain after football practice. He's also going to be okay. You listen to his chest, again, part of our normal ritual, and you hear this. S4 happens just before S1. So instead of lub-dub, you get rub-dub, rub-dub. S4 happens when the atria contract to propel blood into the ventricles and just before the atrioventricular valves close to start systole and give you the S1 sound. That blood reverberates against a stiff ventricle and causes that S4. So rub-dub is reverb blended into atrioventricular valve closure with systole. S4 is just before systole, it's low-pitched, and you may even feel a brief pre-systolic outward movement of the ventricle on the chest wall. So you hear this and you think, in an adult with comorbidities, I would think this S4 would be a non-compliant ventricle due to heart failure or uncontrolled hypertension, maybe a restrictive cardiomyopathy. But Marcus is a young, healthy athlete. Here, we have to consider hypertrophic obstructive cardiomyopathy. So, you ask Marcus a bunch of questions about dizziness or chest pain or anything abnormal during exercise. Nope. He feels fine. And can we go now, Doc? I got to get back to practice. Well, I don't want to blow this off. S4, of course, can be heard in well-trained athletes who just have an awesomely conditioned heart. But there is a fine line between what is called the athlete's heart and hokum. Let's do a screening EKG looking for strain. In this case, I would err on the side of caution and get him into his primary care doctor before going back to play. They may want to do an echo to try to suss out the normal muscular heart of an athlete versus the abnormal ventricular outflow of hypertrophic obstructive cardiomyopathy. Angelica is a 4-year-old girl who has a cough and a runny nose for the past day. She's febrile in the ED, but looks well. Her lungs are clear, her work of breathing is normal. It really looks like a mild upper respiratory tract infection, and you listen to her heart and you hear a musical vibration, like a baby harp. It's soft, it's systolic. You hear it best at the left lower sternal border. Instinctively, you're not worried about Angelica, but you do hear this murmur, so what do you do with this finding? Well, let's work out if it matches a benign, innocent murmur. It's soft, it's systolic, it's asymptomatic. Those are all good qualities. That and the musical vibrations in a young child make you think of Still's murmur. It's a very common innocent murmur that needs no attention at all. We think it's caused by the ventricular outflow, maybe the chordae tendineae, or humming along with the flow of blood in systole. The truth is, we don't really know exactly why this little heart harp plays, but the music is unique. Once you've heard it a few times, you can feel confident that there is not much to do other than to give reassurance for anyone who may be concerned. So Angelica's mom really likes you, and she asks you to register and see Angelica's little sister as well. Annie is a 2-year-old, and she also has a cold. Her lungs are clear, and on auscultation, you hear a constant, low-pitched hum. It's more prominent along the right upper sternal border, but you hear it on the left. In fact, you go back to listen to the lungs in the back, and you hear it there too. Sitting up, you hear it best. You lie her down, and it softens. It's a hum. It's mostly in the cervical area. It seems to be mostly in the venous face. This is a low-pitched, continuous hum. The child is well and has no other corresponding symptoms, so this must be a cervical venous hum. Yep, that's it. This is a very common finding, and it's so common I would just call it normal. It's just the sound of blood returning from the head and neck veins into the right atrium. The slight turbulence in a small frame makes it easier to hear. If you're unsure whether this low-pitched rumble or hum is a cervical venous hum, you can place very light pressure over the jugular for a moment, or have the child turn his or her head to the side to see if you hear a diminish in that rumble. A cervical venous hum is almost always there in a young child if you have a quiet enough room. I'm not asking you to listen for it in everyone, but in case you hear it, there's really no funny business happening. Just keep humming along. Lily is a 3-month-old baby girl who is brought in by Auntie. She's taking care of her today, and Auntie was worried. She's trying to be a very good auntie. She thought Lily maybe felt warm. She didn't have a thermometer, and brought Lily in just to be sure. Lily is a happy, healthy baby, normal vital signs, normal exam. She's doing great. You listen to her little baby chest, and you hear... You do hear a soft, grade 2, early systolic ejection murmur at the upper left sternal border. It radiates to the back. You're about to open your mouth to say the words, "Were you ever told your child has a murmur?" You do it all the time. It helps to verify that maybe this is not a new finding, or just to let them know that you're really paying attention. But you pause for just a moment. You realize that this is a benign murmur for Lily. It's peripheral pulmonary stenosis, a slight narrowing of the distal pulmonary arteries that infants can grow out of as their little lungs continue to develop and adapt to being, used as lungs outside of the womb. You figure, hey, this is a normal finding in this healthy young infant, and Auntie is already blaming herself for the visit, so you decide to go right to the source. Mama. In cases like this, it's worthwhile to do our due diligence, and you talk to Mom over the phone and let her know what you heard, and you send a copy of your note to her pediatrician. The reason for this is that peripheral pulmonary stenosis can be a little harder to distinguish from valvular pulmonic stenosis. If what you hear sounds like it's peripheral, it's in an asymptomatic child, there really is no need for urgent intervention, but it should be followed and worked up if it starts not sounding so peripheral. To flesh this out a little bit more, mild peripheral pulmonary stenosis is not uncommon in children younger than 1. They're often asymptomatic and they grow out of it as their lungs and vasculature mature. Moderate to severe peripheral pulmonary stenosis can occur in children with various syndromes or congenital heart disease. For example, Williams syndrome with their typical facies, connective tissue abnormalities, or Alagille syndrome with lots of liver and heart problems. You can even have peripheral pulmonary stenosis after repair of tetralogy of Fallot or transposition. All of that is to say that all children need and deserve longitudinal care, one person to pay attention to them throughout their lives. And murmurs are an example of something that can be monitored by that same person, maybe a primary care pediatrician or a family physician. It is empowering, though, for us to have this knowledge to know when to be concerned and when to just wait and see. So that's a lot in a short time frame. Next time we'll talk pathologic murmurs and what to do if you hear them. For now, let's summarize benign or innocent murmurs in children. They are common, so much so that they're really just part of the normal distribution. In general, benign murmurs are soft, short, systolic, have a normal S1 and S2, and they're stronger supine. Soft, short, systolic, safe-sounding S1 and S2, stronger supine. An S3 is a rapid distension of the ventricles and can be an incidental finding in a child as long as he or she is totally asymptomatic. It may be one of those, I hear it, but I'm not really worried at this moment. An S4 is blood flow meeting a stiff ventricle. Can also be an incidental finding, but the distinction between athlete's heart, a very well-conditioned muscular heart, and hypertrophic obstructive cardiomyopathy is just not something we should try to do in the ED. So it may not be a cause for alarm now, but we really need to make sure this child is either referred or has very close follow-up and precautionary advice. Still's murmur is the prototypical happy, innocent murmur. It's the musical vibrations across the baby harp chordae tendineae. Nothing to do, fun to hear. A cervical venous hum is a low-pitched, continuous, faint rumble that presents incidentally, so much so that you have heard it before and probably subconsciously processed it as, that's just a baby heart. And finally, peripheral pulmonic stenosis can be normal, and often it is, especially when it's in an infant. There are no symptoms, there's no past medical history or syndromic issues, the infant is young, and definitely before the first year. A rule of thumb is, when in doubt, get some help. And that help may be just a follow-up visit with the child's pediatrician or perhaps more. Today's discussion is mostly there to buttress up the strengths you already have in your physical exam. And just to remind you, it's okay to have a soft, short, systolic murmur and just see how it goes. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.